Good afternoon and welcome to this third module of the PCR webinars on bifurcation lesions. It's third in the series after one on provisional stenting, how to optimally perform provisional. Second one was how to use imaging and physiology in bifurcation PCI. And today is the third one, combining knowledge from the PCR this year, but also from the learning sessions, live formats that were transmitted, and from live cases performed. My name is Goran Stankovic, interventional cardiologist from Belgrade, Serbia, and we set up Bifurcation Continuum as educational format combining PCR webinars, then sessions at PCR, and also PCR online resources. Today we will discuss Culotte technique used in bifurcation lesion, and it's really my pleasure and privilege to have with me in studio Bernard Chevalier from Massy, France, and David Hildig-Smith from Sussex Cardiac Centre in UK. So Bernard, 21 years since you described the Culotte. Do you recall the time, what was the idea, how you got the idea, and what was the main goal at that time?
I think the main goal of the technique was really to provide with a very good coverage of the osteum of the side branch and the good coverage also of the carina with a single layer of the different position carina on osteum of the side branch. So this is really the initial target of the technique.
To fully cover and improve the result.
Yeah.
David, you were PI of EBC2. I think one of the landmark studies comparing Culotte versus provisional. So what are the main findings of that study?
So in that study we took patients who had a true bifurcation, so Medina 111, had a fairly large side branch, so 2.5 millimeters or more, and they were randomly allocated to either Culotte or provisional approach. They also had 5 millimeters or more of disease in the side branch. And what we found at a year was that actually, even in those patients where perhaps you would have initially expected that a two-stent strategy would be required, actually the clinical outcomes comparing provisional and Culotte were almost identical at 1 year, with surprisingly few events, in fact, in either arm. So I think that the operators did a very good job in the study.
Yeah, thanks. But today we will discuss as a main learning objectives when actually we should select two-stent strategy as a planned approach. Then we should learn how to adapt complex stenting techniques to lesion anatomy. And of course, with two of you, we can really learn all the tips and tricks of the Culotte stenting technique. So Dave, after that study we published EBC consensus document. Can you elaborate on what is today indication for planned two-stent strategy?
Yeah, so I think there are two main anatomical groups. This is looking at non-left main stem bifurcations. Two main groups where you would consider using two stents in a planned way. And that would be either where you have two vessels that are significant size, and in the side branch you have quite a long length of side branch osteal disease. So in other words, that the side branch osteal and proximal lesion essentially in its own right warrants stenting. And therefore in that setting you can certainly quite reasonably plan a two-stent Culotte strategy. You can also do a provisional strategy as well, but that's one indication for two stents. Yeah. The second one is where access to the side branch is either very difficult, so once you've secured it, you don't want to let it go, or the lesion in the side branch is sufficiently at risk of being lost. So the side branch itself is sufficiently at risk of being lost that you would similarly decide, well, I'm primarily now going to secure the side branch first. Yeah, so those are the two major indications.
So it doesn't mean that there is only one way of treating side branch first. There are multiple ways of even approaching with provisional, inverted provisional. If we speak, Bernard, about Culotte, what are the main principles behind the Culotte, and why would you recommend someone to select Culotte as the best option if you need two stents up front?
Yes, I think the main principles are the full coverage of the bifurcation. And we consider that two important things. First, we have a minimal overlap, or at least not a full overlap in the proximal part, because we need to minimize this overlap. And we have also a good coverage of the carina, which is something very important. And we have only one layer distal to the carina, which is also very important in both branches, the main branch and the side branch.
To start describing Culotte in details, I think, Dave, maybe you can briefly summarize the approach.
Yes, okay, so if you look at this slide, we've got two slides here and they're divided into the first slide, which is take a true bifurcation lesion with a significant side branch and significant length of lesion. Now on the left-hand column, where you don't have much risk of losing the side branch, and that would be the vast majority of cases, you can do main vessel stenting followed by planned side branch implantation. Now normally that would be in a provisional manner, so you may well end up without the second stent forming the culotte, but the final step of this would be to place a second stent. And that contrasts then with the planned double stent implantation, which we've previously just alluded to. This is similar anatomy, true bifurcation lesion, large side branch, long length of disease at the ostium. And on this occasion, you do have concerns about either losing the side branch or not being able to rewire it once you've stented the main vessel. So in this case, you can do treatment which begins with the side branch. For example, as you can see here, scheduled and ringed in the blue ring, an inverted culotte, which essentially means you stent from main vessel into side branch first before going on to.
And you secure side branch the same way that people do when they do crush, for example. So you have two options. If you are experienced in performing crush, and this is for some reason your preferred strategy, you can stent in a crush manner, side branch first, but you can also do it as inverted provisional, stenting again from the main vessel into the side branch, and then you put second stent either as culotte, elective T-stenting, or inverted tap. It actually just depends how much you pull back your stent from the main vessel in that case. There is a question from the audience, when would you use the Culotte technique in your centers? And I think we can go directly to your case, and this is something that really explains what are the current indications, because this is not frequent anatomy in our labs.
That's right. So, I mean, the question is a good one, because actually, if you look at how often you need to use the culotte, it's not very many times a year for the average operator. So this kind of anatomy that you're seeing at the moment, you've got a side branch which is definitely 2.5 millimeters in diameter. There's certainly 10 millimeters of very tight disease at the ostium. That's a blood vessel which is capable of causing angina in its own right. You want to treat it. But as people watching will recognize, you don't see this anatomy very often. Normally, disease is much more constrained and confined to the very ostium of the side branch, and the need to put two stents is does not need to be considered. In this anatomy, which you may come across a few times a year, then a culotte is a very good option.
Yeah, Bernard, do you agree with that? Would you consider upfront two-stent strategy in this case as well? Or you have intention to start provisional and then decide later on? There are two different ways of performing actually culotte, just depending on the position of the first stent that you put.
Yes, for sure. I think it's a good case for culotte for many reasons. First, we have a long disease on the side branch, and there is little chance that you can achieve an optimal result with only ballooning this side branch. So I think it's a reason to put two stents in this case. We have a relatively Y shape. It's an angle between the two branches around 70 degrees. And the two distal diameters in main branch and in side branch are relatively close. We are in the range of 2.5 to 75. So it's really the nice target for the culotte technique in this case.
Yeah, I see that our audience is also suggesting some planned strategy. One strategy is to start main branch first. Second strategy is to start side branch first. Is there any special advantage or special clinical situation that you would recommend provisional first or inverted first?
I think it's depending on the access of the side branch. In this case, we can see that the angle between the proximal part of the bifurcation and the side branch is not so easy to negotiate with a stent, and probably it will be a little bit difficult to cross through the cell of the main stent if you start with the main branch first. So I would prefer to you go to inverted culotte in this case, meaning that we stent first the side branch, then we stent the main branch in the second step. I think it's typically the situation where the access is difficult that you should consider the inverted culotte. In situation where the access is easier, you can go to stenting on the main branch to secure the main vessel first, and then to consider the second stent in the culotte technique.
Yeah, it's actually a question coming from the audience whether angulation of the side branch decides choice of culotte into true bifurcation with planned two-stent strategy. So how relevant is narrow versus wide angle in selecting which culotte you will select, inverted or provisional?
I think, again, it's a question of access. If we have a very important angle to negotiate to go from the main proximal part to the distal part, we need to consider stenting the side branch first. Particularly if you have calcification at the ostium of the side branch, you have to keep that in mind also because it will reduce the access. It will be more difficult to access. In this case, I think we should start with the side branch.
Yeah. The length of overlap seems to be very important also for people who follow this webinar. Question is, are the results of culotte worse than others because it provides more layers of stent on the artery wall? But overlap and more layers depend how much you want to overlap. It's a recent trend in all bifurcation stenting to minimize overlap, and actually results depends if study is performed in Europe or in Asia. European study, if I recall well, European study culotte was performing better than crash, and in Asia, in DK crash studies, it was the opposite. But I think it just depends how experienced you are with certain technique, how frequently you practice. As Dave, you said, you don't do it every day. It's a technique that you do from time to time, only in anatomy, which really mandates the use of two stents. Otherwise, we don't routinely recommend it, although result is nicer.
Yes, I think it's very important to minimize the overlap in this situation. We don't need to have so many struts in the proximal part, just enough to be sure that we have good coverage of the ostium of the side branch.
Yeah, our attendees want to know how frequently you would consider culotte for distal left main. Is there some limitation in distal left main for culotte?
I think the main limitation could be the angle. If we have really a T-shaped angle, meaning that the angle between the two distal branches is 90 degrees or more, in this situation, maybe we should go back to a T technique, which is probably more appropriate.
Yeah.
But as long as we have a Y shape, an angle which is below 70 degrees, I think culotte is something which is appropriate.
Yeah. Thank you. I fully agree with you. There is a question for Dave, I think specifically, why not tap in this case?
I mean, you could try tap, but of course, once you've got the wires in place and you've placed your first stent, you've narrowed the angle more, you're going to have a little bit of metalwork protruding in a rather untidy manner in isolation in the main vessel Personally, I don't really like that. I like the way with Culotte, you secure metal against all the walls, you secure metal at the carina, and you maintain two large ostia, and you don't have any struts of stent floating.
Yeah.
Really
Can you
in the
lead
middle
us
of the
through
vessel.
the steps of this case? Maybe.
sure.
So it's definitely that you decided to do culotte, wire both branches, and
Yes.
then.
Yes, so you wire both branches. In this case, because as Bernard has said, of the angles involved and the fact that the side branch is the most diseased area, we will stent the side branch first, as you can see in the second image. Then in the third image here, you'll see a very important step, which is the POT, the proximal optimization therapy. That balloon is sized according to the proximal main vessel, not the distal main vessel. So, the distal side branch. The initial stent is sized according to the distal measurement of the side branch. So the proximal optimization is done, that's in the third image. That means that the stent in the fourth image is expanded proximally, and it's also bowed out into the ostium of the, in this case, main vessel. And you can see the wire there is used to cross that stent as distally as possible. If you manage that nicely with the distal crossing, then in the sixth image there, you can recross into the main vessel, undertake a kissing inflation and a further proximal optimization, and here the result in a sort of incomplete procedure so far is that you have the basis of the inverted culotte. If we then go on to complete the procedure, you then inflate a balloon in the main vessel in the first image. In the second image, do a second pot. This is a bit which is often forgotten, but is important and again should be sized appropriately to the diameter of the main vessel proximally. And following that, you can do a sequential and then simultaneous kissing inflation. Finally, if you like, a pot again to circularize the stent at the ostium up to the carina, and there you have your completed culotte.
Yeah. Bernard, ideal case scenario for culotte will be similar, different diameters, narrow angle, wide angle. What is, from your perspective, ideal candidate for culotte?
I think an ideal candidate is a kind of Y-shape bifurcation with relatively narrow angle. I would say 70 degrees or less, no more. Second point, which is important, is the diameter of the two distal branches, which should be relatively similar, meaning that you can use the same type of stent in both branches.
In both branches, yeah.
So if you do that, you can have a similar expansion capability in the proximal part of the bifurcation. And it's very important when you consider your sizing strategy of the two stent to be sure that you can fully overexpand the stent in the proximal part when you do the pot using the classical Finney law, which is the sum of the two diameters multiplied by 2/3.
Yeah. Thanks. Just to summarize for people who attend this webinar, so large size side branch, diffuse disease, preferably similar diameters of both branches, side branch and distal main vessel, narrow angle, and when we stent, we select according to axis, angulation, whether it's stenting from the main vessel into the side branch first, or main vessel first and then second stent towards the side branch. There is a question repeatedly, what is the recommended overlap of the stents in the proximal part of culotte? To clarify, we try to limit as much as possible, and it really depends on presence of disease, length of the proximal segment, how big is that bifurcation. We just need to make sure that at least 1 millimeter we are inside, so we are touching with stent the opposite wall. That's the difference between, if you want to elaborate more, difference between T, TAP, and Culotte. It's actually just how much you pull back your stent inside the one that is previously implanted.
Yes, I think what is important is to place at least the first cell of the second stent in the main branch. Because if you have to recross through the first cell, it's more difficult because the mechanical properties of the stent is a bit different.
Yeah.
So I want to have at least the first cell in the main part and to recross through the second cell.
I think now we can move to your case, and then what you nicely described, maybe now we can really see in a clinical scenario.
Yes, so here you can see on the screen the initial approach to the culotte. So we've decided to do side branch first, 2 wires in the vessels, radial approach, 6 French guide. This is just a simple pre-dilatation with a 2mm balloon into the diagonal, followed by stenting into the diagonal and back into the left main stem. So this is a 2.5 by 18mm stent in this case.
And to clarify for people, it's actually based on diameter of diagonal.
Exactly.
That you will adequately expand later on.
Exactly. So it's deliberately undersized for the main vessel. It's a mistake to put in a stent that's the size of the main vessel because you cause dissection in the side branch. So this is deliberately the size of the side branch. And as part of that, it's then very important to do the next step, which is the proximal optimization. So this is with a larger balloon. In this case, it would have been a 3.5 balloon probably, in order to make sure that the stent is now fully opposed to the wall of the LAD. If you miss that bit out, then you've every chance of passing with a wire underneath the stent struts because it's significantly undersized, malopposed in the proximal LAD.
Yeah, we saw it also on the figure that you really have gross under expansion.
Yeah.
And then we need to do pot. Any tips and tricks, Bernard, regarding the selection of pot at this point?
I think the first tips and tricks, which is very important, is to have enough struts in the proximal part to be sure that you can cover with your balloon, but not to be outside the stent. So if you have only 6 or 8mm balloon, for example, you should have at least 6 or 8mm of stent in the main part of the vessel. This is the first point which is important.
Yeah. The length of the proximal, so you intentionally pull back stent enough to allow you to perform proximal optimization.
Yes, it's very important to anticipate that when you place the first stent. The second point which is important is to use a short balloon to place it at the level of the carina, up to the carina. You should do that very precisely, and you should consider the fact that the distal marker of your balloon is not always at the same place as the shoulder of the balloon. So you need to know the balloon
material that you are using.
You are going to use. It's very important. Otherwise, you can go too far and create some injury on the LED in this case.
Can I ask you just practical question? I frequently got that question from the audience. Are you using routinely compliant, semi-compliant, or non-compliant balloon for pot? Does it depend on certain characteristics of balloon or lesions that you are selecting? Is there any general advice how to select balloon for pot?
I usually use non-compliant balloon, but I think you can also use semi-compliant balloon if you know that you are not going to very high pressure. Yeah. If it's a calcified lesion and you need, for example, 20 atmospheres to improve the situation, probably you should consider non-compliant balloon. So I consider the calcification of the lesion to make the choice between non-compliant and semi-compliant balloon. Another important point for the pot is to be sure that you are in the right view, because otherwise, if you have too much overlap between the two distal parts of the bifurcation, you may have a wrong placement of the balloon for the pot. So the right view is the view which is provide you the most important divergence between the
So
the
you do
two
it actually
wires.
at the beginning of procedure. You decide what is the projection. You try in which projection you really open the most bifurcation, and then you try to position devices in that projection. The next step will be to dilate struts towards the main vessel, and there is question from the audience about predilatation. We saw that you don't routinely predilate both vessels because question is about possible dissection of the main vessel and whether you change strategy. If you dissect main vessel, can you still proceed with inverted, or you then convert to provisional culotte?
Yeah, I mean, this is one of the central tenets coming out of the European Bifurcation Club, really, is that if you can avoid having to predilate side branches, then you should do it. Because yes, there's a risk, and it's been shown in some studies that where predilatation has been done in what is, it doesn't have to be the side branch, but whichever branch is going to be jailed and you have to rewire. If you've already done a predilatation, then you do risk passing your new wire, your third wire, into a dissection plane, and then things can get messy. So yes, ideally you want to avoid predilatation, and you want to get to the point where you've secured the vessel before you undertake some dilatations.
Bernard, you do the same, or you sometimes predilate both branches if you plan to do culotte up front? What is your experience?
It's really depending on the calcification or no calcification. If it's a soft, we expect a soft lesion, we can consider to use direct stenting. And if it's not the situation, stable patient, elderly, calcified lesion by angiography, I would predilate.
So let's see, Dave, next step after pot was predilate. There is a question about use of imaging to make certain that you have good apposition. Do you think it's routine or it's case-based decision?
That's a different webinar, really, isn't it? An imaging one. I mean, of course, there's nothing wrong with using imaging. Equally, people have had lots of experience of using appropriate size stents in vessels and getting to know what the likely size of the vessel is. So I think it's not mandatory. Some people will like to use it.
Bernard, do you agree? How frequently you use imaging to make sure that you have good apposition?
Oh, it's really on demand. I think if you follow very well the different steps, particularly the sizing strategy for the different steps, I think the need for systematic imaging is not there. But of course, we have to consider on demand in some specific situation.
So let's proceed with the case. So you predilated?
Yeah, so just to recap, we've done the pot, having stented the side branch. We've now used a third wire to recross through the distal cell of that stent into the LAD. Having done so, we've chosen here to predilate with a 2mm balloon, and then then stent. Sorry, we'll do this bit. And then stent the LAD, and you can see here we've used quite a short overlap, because one of the questions that was coming up, with only a few millimeters really of overlap, where we've got double layer of stent. I'll just go back to
we go back just to share with people the. Now we proceed. This is a visible heart model. It's actually animal model. It's a pig heart, but it's beating heart and it's perfused. So we use angioscopy to review from inside coronary artery different steps of bifurcation stenting. And it's done in cooperation with Medtronic and University of Minnesota. So we tested multiple bifurcation stenting techniques, and we really detected so many errors that we are performing after looking from inside. And actually this is initial part of the inverted culotte, stenting from the LAD to the right, which is diagonal branch here. and then after opening, after proximal optimization, kissing was actually performed. So you see on the left side wide open access towards the distal part of the LAD, and this is actually the step that you select stenting. And for stenting, if you have such good opening, you can actually select stent size again according to distal LAD diameter. So you did that one. Maybe we go to next slide and you describe how you selected what stent and what was the length of overlap.
Yeah, so now the stent in the LAD, so this is a, I think in this case actually it was a 275 by 28, thereabouts. It looks like a 3 from here, but I'm very far away, with a little bit of overlap in the most proximal area. So that's sized according to the LAD, and we will now, and this is a step which people...
Let me ask you, you left the jailed wire during the stenting, and there is also a question people would like to know more. Are you recommending actually jailing wire during deployment of the second stent or not?
I mean, I don't recommend it, and I always used to take it out, but then I forgot a couple of times, and it seemed to be fine. So I don't really mind. I don't think it seems to be much of a problem, actually.
Yeah.
I don't know if you agree.
Yes, usually there is no issue to remove this wire, but of course this wire is no longer useful, so you can remove it.
Yes, yes. And I mean, probably only once you've done the pot could you possibly, you know, really squeeze it tightly. But anyway, so this second pot is the bit which people often forget.
Yeah, so this is...
Sorry, which is there.
Yes.
And I'll go back now to the visible heart again.
Okay, so we go back to visible heart just to demonstrate how stenting of the main vessel looks really from inside. And you see now easy passage of the stent into the distal part of the main vessel. Here in this case, what we would do today differently, unintentionally long overlap was performed. But what we can learn and appreciate is the difference in diameters between proximal and distal part of the main vessel, because there is no tapering. There is a step down in diameter, and you can clearly appreciate that there is a gap. So that's why your next step was selection of the pot. You use the same balloon that you used before, so you don't open new balloon now.
Yeah, probably, yes.
And what would be the consequence? We can see now pot, and look now gap and malposition proximally. And after upsizing of the balloon size, we will see the result, which is really much better stent expansion in the position. Compared to this, after pot, you really maximally achieve good expansion also proximally. Dave, where do you place distal marker of balloon during pot? What are the landmarks? This is the question from...
Yeah, so as Bernard has said, you have to know the balloon that you're using, because they are different, and the shoulder of the balloon comes in a slightly different place with different balloons. But broadly speaking, you're putting the distal marker of the balloon right at the carina. And then if you inflate it there, you're going to expand the stent in that polygon of confluence and push the stent struts into the side branch. So that's the right place.
And do you confirm position in two different projections, or you select one in the beginning and then you focus and work in that one?
You probably should. I mean, I think with different bifurcations, you learn where the best view is for each particular bifurcation. So, for example, left main, of course, it will tend to be LAO caudal. In the LAD diagonal, which is the vast majority of these cases, then it's usually you'll get a good view in one of the cranial projections. But you can check in a...
You mentioned already the importance of distal strut recrossing, and there are multiple questions related to that one. What is the current practice? How you make certain that you are crossing distal strut, and why it's so important to cross distal strut?
Yeah, so unless you have A, lots of money, and B, lots of time, most people don't check with OCT or something like that. You can. Most people, what you will do is, having done the pot so that you don't go under the stent with your wire, you'll loop your wire with a complete J, pass it down the main stent, and then come back slowly, slowly, slowly with a nice curve on your wire, and try to see it drop in to that distal cell. Okay, it's not always possible to be completely accurate, but you do your best to make sure you get in the distal cell. And the reason for that is that when you then inflate with a balloon, you push those stent struts against the external.
And you remove metal from the carina, so extra metal of carina.
Yes.
I remember from a couple of cases that if you don't really cross distal, there is some hazy appearance that never disappears until the end of procedure. If you once cross too proximal, then there is a metal that with the sort of sequential balloon inflation, you are just shifting to one or the other side of. Bernard, any special tips and tricks to add on this one? How to make sure that you cross distally?
You cannot be sure if you don't check by OCT or FDI for sure. So I think the best way is to go from the distal part of the bifurcation in the vessel, in the part of the vessel you are not placed to be crossed. Meaning that if you want to go, for example, in the diagonal, you place your wire in the LED distal to the bifurcation with a nice curve. Curve should be long enough than the diameter of the artery. So that means if you are in a 3-0, you make a 3-0 millimeter curve. And you go back very slowly and turning a little bit to go in the direction of the diagonal. And in this situation, you have more chance to get the distal cell. But of course, it's also depending where the struts are, and you are not controlling that.
Exactly. I know that if you have jailed wire, and jailed wire is between the stent and the vessel wall, if you are able to cross distally, then you see clearly separation between two wires. So that separation is also one of the signs that you are distally, maybe not the most distal cell, but distal compared to.
That's true. If the two wires are superimposed, you are not in the wrong.
You are not. You are definitely in the wrong one. Another question, it's very practical. Is it a good idea to remove jailed wire only after trading balloon on recrossed wire? So you keep jailed wire to stabilize guiding catheter position and to provide more support. So what is your perspective on that one?
No, I don't really think that's not the purpose of the jailed wire. And really in the bifurcation cases, if you're having to push with your equipment, then something isn't quite right. You know, if I know it's not always possible to do this, but if you do it and follow the steps, there shouldn't really at any stage be major resistance to you delivering your equipment.
It's probably you are in the wrong strut. It's better, instead of forcefully pushing, to take another wire and try to select another cell and then try to do it. Okay, maybe we go on after pot.
Yes.
You do very important step, and I think mandatory for two-stent techniques, kissing.
Yes. So the kissing, and I agree. I think this is important in the two-stent techniques to do, I suppose aggressive is the wrong word, but a very determined kissing technique. And that means that each individual ostium, if you like, of the bifurcation should be dilated to the correct size with a balloon that will make sure that you have really opened the ostium to a circular level. And that usually means high pressure. So a correctly sized balloon to high pressure, so you do it sequentially. Doesn't matter which first, perhaps side branch to high pressure, main branch to high pressure, and then finally
And just
kissing
for the
inflation at lower pressure.
just for the audience, size of those balloons is actually stent size. It's size of the reference distally.
Exactly.
You don't oversize.
Yes. No, you don't oversize. It's exactly the same size as the size of the stents that you put in. Yeah.
But of course, you also don't undersize, because sometimes people say, I will do gentle kissing with smaller balloons. That's a waste of time, because you always shift metallic carina in that case with larger balloon towards the smaller balloon. So sequence is separate inflations, irrespective side branch first or main branch first, and then simultaneous, so 3 steps.
Yeah, for me it is. I don't think it matters particularly which you do first, but it's very important that you open the side branch, stent, ostium to high pressure to make sure that the stent is fully opposed there. And then at the end, it's a kiss at a lower pressure just to reorganize any metal neocarina.
And actually position carina in the center.
Exactly.
Bernard, can we do it without deflating each time? What is the way you perform kissing? Is the same, or?
Usually I inflate first the side branch with relatively high pressure, at least 10 to 12 atmospheres, sometimes more if it's...
Until you see that it's fully open.
If it's resistant. So and after I inflate the second balloon in the main vessel to perform the kissing. So it's a side branch first, then kissing balloon, and I deflate together.
Yeah. Maybe we can just make comparison provisional, kissing in provisional stenting versus kissing in two-stent strategy. After both stents are implanted, is there any difference? And actually, what are your indications for kissing in provisional?
It's a good question. It's a big matter of...
it's privilege of sitting here. So.
It's a big matter of debate. I think kissing is depending on, of course, if you kiss after provisional stenting, you create a risk to have a dissection and put a second stent. If you don't do kissing, you are not sure about the late patency of the side branch. So I think it's a decision case by case, considering the initial type of disease and the outcome after the main branch technique. I think there is no strict rules to apply kissing or not doing kissing in provisional approach. Really, it's a case-by-case decision.
Yeah. What I learned, or at least what is my practice, if you have a large side branch according to Finet or Murray means big step down between proximal and distal part of the main vessel. And there is really discrepancy in diameter. So for large side branches, big first diagonal or left main with big circ, I think in those large side branches you need kissing in order to better expand stent proximally, and you do kissing also in order to position carina in the center. There is alternative pot kiss pot on one side versus pot side pot. And in France, I know people like and they test a lot pot side pot. What do you think is the role of pot side pot?
In my practice, there is no role of pot side pot, because I think when you do only a side branch opening, you create some distortion in the main part, and this distortion is very difficult to be corrected only with a pot. Except if you do a very distal pot, and if you do that, you create again a risk of shift of the carina.
Shift carina.
So I think there is no place, in my opinion, of pot side pot, but of course it's a personal opinion.
Dave, you agree with that?
Yes, completely.
Yeah, so just to say, we are collecting evidence. There is ongoing study in France. So before we recommend really pot side pot to replace pot kiss pot, I think we should collect more evidence. From personal experience as well, I share your opinion that pot kiss pot is more predictable, and we achieve what we would like, better expansion of the stent proximally and position of the carina in the center. And this is visible heart. Again, if we focus on these images, what we see is that we use short balloons for kissing, usually non-compliant short balloons with very short proximal. You can appreciate that only in the polygon of confluence we have two balloons which are overlapped. And by doing that, we try to avoid elliptical deformation of the stent in the proximal part. And after this inflation, what is, Dave, the final result that you achieved? I think really looks angiographically perfect.
Yeah, looks quite nice. Yeah.
Decision to perform final pot is based on what, length of proximal extension, or?
Yeah, I mean, I think it probably doesn't really matter if the proximal bit of the stent is a little elliptical. That's just aesthetics. But what you do need to do is make sure that whether it's with the kissing inflation or with an individual pot, you actually come back to the start of your stent. People often forget that as well. They just kiss at the bifurcation and think, oh, we're finished now. You must make sure that you...
Yeah, especially when you inflate two balloons simultaneously, which are big balloons, you have partial collapse of the proximal edge.
Yes.
And if we speak about final pot should be more proximal compared to initial. Bernard, do you agree with that? You have some special comments, or?
Yes, I think we have to consider the risk of what we call the bottleneck effect. If you have a two proximal kissing balloon inflation, this is why the very last pot, proximal pot, not necessarily going to the carina, is important, in my opinion, in very large bifurcation, particularly in the left main, because in the left main you have another risk of conflict between the first strut of the stent and the guiding catheter.
Yeah, there are just coming more questions about kissing. During kissing, do you prefer using two indeflators or one indeflator with the stopcock?
I use two indeflators because I'm not always using the same pressure on the two balloons.
Yeah. Okay, so that's very important technical advice. Dave, I hope you agree.
I agree.
And for kissing, should we use non-compliant or semi-compliant balloons? Depends on what whoever wants to take it.
Well, I always use non-compliant balloons simply because a similar reason about pressure, which is that you may be wanting to go to really quite high pressure in one or other branch. So you don't necessarily want to do that with a compliant balloon, especially, we're not talking about it today because we're talking about culotte, but especially if you don't have a stent in the side branch. If you're doing a provisional and you use a compliant balloon, it will grow and expand and you risk dissection, so non-compliant.
You agree?
Yes, I agree. Same approach. I think, again, it's a question of how high you want to go in terms of pressure due to the possible resistance of the lesion.
Yeah, and this is the final image. Maybe Bernard is the father of this technique. Are you happy how we performed in animal model? You see really nice coverage of carina.
Yes, I think we see very well what is, in my opinion, the main advantage of the technique, which is the quality of the coverage of the two ostia, of the carina. You can see very well the carina with a nice coverage, not overlap of the stent at this level. We see that, of course, we have probably a little bit too much in terms of overlap in the proximal part.
Yeah, unnecessarily.
Probably really don't need that in this case. But I think it's a very nice example, and I'm very happy to see that.
If I jump to the next one, it's even nicer. This is a micro CT, and fly through. We have stent in the side branch in blue, one in the main vessel in black, and except for a little longer than we would do it today, proximal overlap, we see nice opening. Modern stents are with the semi-open or completely open cell design. Do you have any particular stent that you will recommend, or it depends on what is available in the cath lab?
Yes, I think you can do culotte with all type of modern DES. There is no real importance of the stent selection, except the fact that you should know your stent, you should know the sizing of your stent, you should know the overexpansion capability of the stent. So it's very important to use a stent you use in daily practice for that.
Yeah. Few more practical technical questions. In case cost control is the issue, can we avoid the third wire by using wire from the stent in branch? by shaping it for the first recross, Dave, you said you used the third wire.
Yes, you can do, but you know, one day you'll wish you hadn't pulled the wire out of the main vessel. So, you know, the wire is a rather small proportion of the cost of these cases.
Agree.
The issue of the guiding catheter, are you able to do this procedure with 6 French? You do it 6 French?
Yes.
If so, how difficult was the NC kissing in terms of deliverability of the balloons?
No, it's really fine now. You know, they're very good, very deliverable. I mean, 10 years ago it wasn't so straightforward, perhaps, but now it's really not an issue.
So for Culotte, whether it's left main, non-left main bifurcation, 6 French is your standard strategy. No need to go for 7 French.
I don't think so. Of course, if we consider the distal left main lesion, we may need to have a 7 French because you may have a need for
4035 non-compliant, then you can have really
5 mm or 6 mm balloon to do the pot. So, but for non-left main bifurcation, all the 6 French guiding catheters are fine.
Always the same question at every bifurcation session. Before the first pot, did you pull back the wire from the LAD?
No, never.
No.
So that fear does not exist any longer.
Yes, and it's really important that people understand that why you're doing the pot and at which stage you rewire. So you know the pot must happen, and you mustn't be frightened of, you know, leaving the wire there until you've completed the pot and rewired, because otherwise you potentially remove the safety feature that allows you to rewire that vessel.
Bernard, any comments? No.
No, I think clearly we should keep it. We should not remove this wire because the risk always is to rewire in the wrong situation below the strut.
Yeah, and it frequently occurs that at follow-up you just realize, because angiographically at the end of procedure looks beautiful, and when patient comes for follow-up and for example for restenosis you do imaging, and then you realize that actually your wire went outside and you have partial crush of the
And you have a double lumen stent.
Double lumen stent that you don't really realize during the procedure. So I think one of the major steps in the evolution of bifurcation PCI is development of POT as mandatory step. And for POT, I think we did not discuss enough. Can you use do you always use non-compliant, or there are some instances that you would consider semi-compliant balloon for POT? Depends on...
I usually use non-compliant because I think we may need to use high pressure in this situation, so I prefer to use non-compliant balloon.
Any specific type of the wire we also did not comment in many details. What kind of wires you use for bifurcations, especially in this case for the side branch? If you need to recross, you use workhorse wires? Or?
Yeah, I would use the workhorse wire and only consider something different if you really can't get through with that. It's usually best to use the wire you're most familiar with. And just on the subject of the compliant and non-compliant balloons, I'm not really sure what compliant balloons are for anymore, because a non-compliant balloon is so trackable and deliverable that you can use it, and if you need to go to high pressure, you can. So I use them very routinely.
Yeah, some of the comments are usually that by increasing pressure in the compliant balloon, you can actually better expand the stent. At least this is what imaging has shown. I don't know if it's a reality in the patient coronary artery. Does it really mean that?
Yeah, I think it depends.
Maybe for left main, that you are already inside the aorta, you want to better expand stent at the ostium and to flare what is protruding. Maybe compliant balloon is better option. So by increasing pressure, you flare also ostium of the left main.
Maybe.
Maybe, but you stay with 2 non-compliant balloons.
Yeah. Yeah, you have
non-compliant
the
for
versatility.
kissing. Yeah, non-compliant for kissing, non-compliant for pot.
Yeah.
6 French, workhorse wires, predilatation of the side branch, not routine predilatation of the other branch, and then you follow actually the sequence of provisional. You just decide up front if you need two-stent strategy in those scenarios that risk of losing the side branch from your perspective is too high.
Yeah.
Yeah. Bernard, your selection of upfront two-stent strategy is based on similar principles, or?
Yes, I think it's based on the anatomical situation. So first step is to analyze the angiography to have a good knowledge of the lesion you are going to treat.
Yeah. Question about architecture of the currently available stents. I think we already partially answered that question, but question is the maximum expanded cell diameter of some architectures could create stent waste. This is after disappearance of Cypher. It's not the case anymore.
No.
I think most currently available stents are semi-open or open design. So if you want, and if you find Culotte as strategy, which is for your perception, good option, safe option to treat both branches, I think you should not be worried about the specific stent that is needed. You can actually learn the steps and you can apply most of the currently available devices in your lab. Question is why you didn't do a final pot in your case. Is there any specific reason for that? Or?
I mean, you can do, and many people would recommend that. I think it's not unreasonable also to take the 2 kissing balloons, bring them back to the beginning of your stent and inflate them, probably to lowish pressure there. Yes, the stent will be a little bit elliptical, but as I said before, that's really just an aesthetic consideration.
Yeah. Any final comments, something that you would like to stress that we did not touch during this webinar?
No, I think we have touched all the many very important steps. I think what is important again is to start with a good analysis of the lesion, good knowledge of the anatomy of the patient, good selection of the view, good support with your guiding catheter.
Yeah.
So the selection of the guiding catheter is something which is very important, and it's the first key of the success.
I think we should just share the message that if you select Culotte, you need to learn the steps. You need to learn the philosophy when you go with provisional stenting main vessel first, or when you stent the same way, inverted provisional stenting from the main vessel into the side, what you did, Dave, in this specific case. But key messages is that first, in most cases, stepwise provisional is still preferable approach, and this is also recognized by the guidelines. What is important is that provisional is also philosophy. Provisional does not mean you stop with one stent. Actually, at every step of the provisional, you can change and go to 2-stent strategy. You can do Culotte as a provisional. This is a really valid option. After performing kissing, if you don't like the result at the ostium of the side branch, you can always continue with T-tap or Culotte. Actually, the main difference is how much you pull back your stent from the side branch into the main vessel. And this is a Culotte session, so we should consider Culotte if we have a large side branch with significant length of ostium disease that we want to stent. But we also could select inverted Culotte as the preferred approach in case of difficult side branch access, or if we estimate the very high risk of losing the side branch. In this case, it was really big diagonal. There is only one more distal small diagonal branch. So that diagonal was definitely clinically relevant, so we don't want to lose it. And because disease was more than 10 millimeters at the ostium, I fully agree with your decision to start by protecting side branch. and your personal preferred strategy was Culotte.
Yeah.
And that's probably one of the reasons why we want to learn today from both of you, from the father and from you as a PI.
Son.
And yeah, of course. And it's very important to say that if we select father and son, yeah. If we select two-stent strategy, pot and final kissing are very essential steps in whatever two-stent strategy you select. So now we reach the end of this Module 3 PCR webinar of our bifurcation continuum. We hope, all three of us, that you found this useful. On behalf of my colleagues, I would like to thank the Medtronic for supporting this independent series of educational programs on bifurcation PCI. The next PCR webinar will be entitled Case-Based Step-by-Step Decay Crush in Bifurcation Lesion, and it will be live on September 5th, so we can see what are the indications for decay crush up front. Is there any difference, or it's just operator experience and preference? And I wish all of you the best from three of us. Thank you very much.
Thank you.